introduced before, I'm currently working as a clinical teaching and research fellow within the Bariatric Surgery department in University Hospital Ayr in Scotland, United Kingdom. It's a pleasure for me to be able to speak here today and share the findings of a retrospective study that I've done together with the bariatric team here regarding the impact of bariatric surgery on renal function. So I'll just go ahead and go through my presentation. So I would like to start by talking a little bit about obesity. Obesity is becoming a significant problem worldwide, and some may even regard it as a chronic disease, although it is non-communicable. As with other chronic diseases, obesity results from interactions between an individual's genetic predispositions to weight gain and environmental influences. As we all know, obesity has become an epidemic worldwide. According to the World Health Organization, 39% of adults.
Can you please switch off the mic? Yes. Can you please switch off the mic, Abrilina? Sorry. Sorry, Dr. Dickson, for the.
Right. Okay. Okay. So just to continue, according to the World Health Organization's 39% of adults aged 18 years and over were overweight in 2016, out of which 13% were obese. This means that those 13% had BMI of 30 kilogram per meter square as per WHO definitions of obesity. Obesity, as we're all aware, can be related to metabolic syndrome, which can have severe consequences if not addressed early. Furthermore, obesity can be classified into different classes, which we all will see in the next slide. So going through this table is a table that I have quoted from a paper in 2018, showing the categorizations of different weight groups. I would like to focus on the classes of obesity, as we all can see here. There are three main classes depending on patient's BMI. So logically, thinking about this, the higher the BMI, the higher the class, and therefore the higher the risk of an individual to develop disease related to obesity. This is as compared to individual with normal weight and waist circumference. So previously, as I've mentioned, that obesity is related to several diseases. One example of a group of diseases that are linked to obesity, as we all familiar with, is metabolic syndrome. This syndrome includes type 2 diabetes mellitus, hypertension, and hyperlipidemia. Some paper has also mentioned that obesity is also related to chronic kidney disease. So I'm now going to just touch briefly regarding the relation between obesity and chronic kidney disease. A high body mass index is one of the strongest risk factors for new onset chronic kidney disease. In individuals affected by obesity, a compensatory hyperfiltration occurs to meet the heightened metabolic demands of the increased body weight. The increase in intraglomerular pressure can damage the kidneys and raise the risk of developing chronic kidney disease in the long term. The incidence of obesity-related glomerulopathy has increased tenfold in recent years. Obesity has also been shown to be a risk factor for nephrolithiasis, that's the developing of the stone in the kidney, and for a number of malignancies, including kidney cancer. So taking that in mind, weight loss would logically help to either prevent an obese patient from developing chronic kidney disease or even slowing the rate of progressions of chronic kidney disease. One of the tools to help patients to lose weight, so I'm mentioning a tool here as bariatric surgery is not the answer to lose weight, but it's as a tool to help patients to lose weight. It is through bariatric surgery. which is by itself is related to several risks, including acute kidney injury that may develop into chronic kidney disease. There are publications that mentions that bariatric surgery improves patients' renal functions. However, on the contrary, there are others who opine that bariatric surgery does not have effect or even worsen renal functions in obese patients. That's why we are interested here in studying the impact of bariatric surgery has on kidney functions of obese patients. So just a little bit about bariatric surgery. I'm sure everyone's familiar with it. It involves surgical manipulations of the gastrointestinal tract with achieving weight loss as the primary objective. There are many types of bariatric surgery, but mainly, to summarize it, they can be divided into two main groups, which are restrictive and restrictive malabsorptive. The name describes the way they help with weight loss. In the restrictive group, patients have smaller capacity of stomach and therefore feels early satiety and reductions of food intake. In the restrictive malabsorptive group, manipulations of gastrointestinal tract to reduce food capacity as well as reductions of food absorptions, therefore helping lose of the weight through that way. So the examples for restrictive bariatric surgery are gastric banding, sleeve gastrectomy, distal gastric or jejunal-ileal bypass, while the examples of restrictive malabsorptive is Roux-en-Y gastric bypass. So now touching about the paper that we have published. This slide shows the method that we have of the study. So this study is a cross-sectional single-center study performed by analyzing data from November 2009 to June 2018 among 307 patients who underwent bariatric surgery of either gastric sleeve or gastric bypass procedure. The data collected were those relevant to calculate creatinine clearance through the use of Cockcroft-Gault equations. The point of time of interest for the study are at preoperative, surgery, at 1, 2, and 3rd year of postoperative. Renal functions can be assessed by various methods. In this study, creatinine clearance was used as it provides an evidence-based, cost-effective, and minimally invasive assessment of renal functions. The creatinine is a product of creatine and phosphocreatine metabolism found in skeletal muscle, freely filtered by glomerulus and not reabsorbed throughout the tubules, or minimally reabsorbed throughout the tubules, mainly in the proximal tubules. This makes creatinine to be an ideal endogenous substance for glomerular filtration rate measurement and therefore was used in this study. One-way ANOVA Welch calculations with a Games whole post-hoc test was done in order to assess the significance of the difference in creatinine clearance between time points of interest. A 5% significant critical level for creatinine clearance was adopted. Patients with insufficient data defined as lacking the variable of interest at operative time 1, 2, and 3 years postoperatively, they were excluded. This is after introductions of patients number from 145 at time of surgery, 237 at 1 year following surgery, 119 at 2 years following surgery, and 93 at 3rd year following surgery, which I'll show you the summary of the slide later on. So the results, what did we find? Out of the total 307 patients in total undergoing bariatric surgery, data for 145 patients were available, of which 44 patients, that is 30.3%, were male. Out of 145 patients, 57.9% underwent gastric sleeve, and the rest underwent gastric bypass for their bariatric surgery. The type of surgery decided for each patient were not randomized or affected by this study. They are based on the local guidelines as well as multidisciplinary team and patient discussion. Following that, 67.6%, that is 98 patients, included in the study had type 2 diabetes mellitus, and only 6.1% of them were diet controlled.
Yeah. Okay.
The average age of patients at referral was 48.1, with standard deviation of 8.6 years, and the average age at surgery was 49.1 years.
Excuse me, Audrey. Could you please just mute your mic, please, so that the speaker can deliver his speech? Sorry for that.
No, that's okay. So we're sorry. So the average age at surgery was 49.1 years. The average BMI at referral was 47.96 with standard deviation of 7.9 kilogram per meter square. And the average at surgery was 40.62 with the standard deviations of 44.2 kilogram per meter square. So this initially reflects net mandatory preoperative weight loss. The importance of a preoperative weight loss. Since the surgical procedure is going to be done laparoscopically, the reductions in BMI is not only reduces the complexity of the procedure, but also reduces patients' risk from anesthetic agent, as well as improving post-operative recovery. The preoperative weight loss was likely to be achieved through weight loss programs available to patients who were referred to the bariatric unit. So this slide showing a table that we constructed to show the mean creatinine clearance at surgery and post-operatively. As in this table, when comparing the mean creatinine clearance, the value at surgery was 172.35 with standard deviation of 53.29, and at year 1 is 179.2. Year 2, there is a decrease of 142.35, and year 3 is 119.56. When we compare the mean value of creatinine clearance at the time of surgery to year 1, year 2, and year 3, we can notice the reductions in the number of patients, that's with the available data as the year passes from operative time all the way to year 3 post-operatively. Initially, there were 145 patients I mentioned before, and eventually at year 3 post-operative, there were only 93 patients with data that was available. We took this into account into our statistical analysis. The next slide shows the mean creatinine clearance versus post-operative years with 95% confidence interval. As in this figure, there was a marginal improvement in creatinine clearance at year 1 postoperatively from 172.35 to 179.20. However, as we all will see in the next table, this improvement was not statistically significant. It also shows the reductions in the value of creatinine clearance from year 1 to year 2 and from year 2 to year 3 postoperatively. So the next table is showing the Games Hall post-hoc test. This table showing the differences of creatinine clearance between each time of interest, as well as showing the P and T value of each comparison or the differences. So as we can see in this table, there was a statistically significant difference in creatinine clearance from year 1 to year 2 postoperatively, and from year 2 to year 3 postoperatively. So if you can see at this one and this one, okay. So those were all have a p-value of less than 0.001. So all those with the 3 stars. You can also see the previously mentioned statistically statistically insignificant marginal improvement from operative time to year 1 postoperatively. So just about here, with the p-value of 0.731, therefore making it insignificant. So what have we concluded? So we concluded that from this retrospective study, it showed statistical insignificant marginal improvement in creatinine clearance between operative time to 1 year postoperatively. This finding is similar to that of a retrospective study published in 2018, which compared laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastrectomy, which showed improvement of renal functions, albeit what the difference between this study and the study I mentioned is that the study in 2018 showed the improvements is 2 years following surgery. We also observed that there was a steady decline in creatinine clearance beyond 1 year postoperatively, in which differences between year to year were statistically significant. This finding is similar to a case report study that showed renal failure is a recognized complication of bariatric surgery, especially when techniques used are Roux-en-Y gastric bypass or jejunal ileal bypass. So those are the ones that can cause malabsorptions as well. Although in the case report, the case of renal failure in the mentioned to be acute, caused by diarrhea, plus minus vomiting, or intratubular calcium oxalate depositions, which is in relations to the malabsorptions from the surgery. This cause is likely to be reversible, initially given careful monitoring. Despite the observed changes that we have mentioned above, the average creatinine clearance remain within normal range for each sex. So what are the possible reasonings for the changes that we have observed? The reason for the change in creatinine clearance remains uncertain, and this could be multifactorial. One of the factors that we did not take into account of their significance is patient's past medical history, as well as lifestyle, which can have great impact on patient's renal functions. Another factor that we didn't take into account was the progress in patient's weight loss. For all we know, as we mentioned before, even if someone have bariatric surgery, they don't have 100% chance of losing weight. It all depends on how the patients work with the surgery. So therefore, the progressions of patient's weight might play an important role. They might not even lose significant weight to have any effect to their kidney functions. So additionally, the Cockcroft-Gault equations that we use utilizes body weight as a factor in the equations. Given that patients in the study lie within the extreme ends of obesity and all underwent procedures to lose weight, these factors reduce the reliability of the Cockcroft-Gault equations in this scenario. So just mentioning some limitations from this study. Firstly, regarding the use of creatinine clearance, while creatinine is a reliable endogenous substance to measure renal functions, there is an even better substance, although being exogenous, to measure renal functions. The substance mentioned is inulin. We did not make use of this because it's expensive, and our study was retrospective in nature, so we could not provide inulin at the time of interest. Which brings me to the second limitation of this paper. It's a retrospective study. Therefore, no randomizations was done and no control over exposure of patients to factors that may be affecting the renal functions. Additionally, this study was single-centered and therefore it is not representative of population as a whole. So our plan for in the future, looking at these observable changes, there are several plans for the future based on the limitations that I have mentioned prior. So further study, preferably a prospective study, should be performed in a randomized controlled manner, thus allowing the control of environmental factors exposed to patients that may affect patients' renal functions, therefore reducing bias. The use of inulin will be the next step as to provide a more reliable measurement of renal functions. When further studies are planned, they should take into account factors such as comorbidities and lifestyle calculate their significant on renal functions. We also have undertaken a study regarding the effect of bariatric surgery on the diabetes, on whether it improves diabetes and their remissions, length of remissions, and that should be combined with the study to see if that have any effect, as we all know the side effect of diabetes in the long term. That will be the end of the presentations, and thank you for your attentions. It was clear and useful. Further input is appreciated if you have any idea on how the next study could be done better. Thank you very much.
Thank you very much, Dr. Dickson, for this interesting research. And I wonder if anybody have a question from the audience. Yeah. Well, I have a question, Dr. Dickson.
Yep.
Is there any possibility that socio-demographic factors in terms of ethnicity, age, could be one of the confounder you need to control for in the next study? And what is the role also of knowing the medication that patient use, especially over-the-counter non-said medication, for example, that might affect the renal function? Those patients went for like bariatric surgery.
Yeah, no, that is a good question. So our study is a single-centered study, which means that the population is mostly a white Scottish populations, and that should the ethnicity and the socio-demographic background should definitely be taken into account, because we all know people there are several group of populations that are more exposed to renal functions issue. Regarding the medications, that is another thing that we should take into account. We are quite fortunate here in Scotland with the availability of KAI number, which means that we are able to access every single persons or patients who have been admitted to the hospital or GP, and we are able to see what medications they are taking, although we might not be able to see their over-the-counter medications. So that's a good point. So we will take into account of that in the next paper.